Well, thank you very much. It's humbling to follow that panel, and particularly Dan. I'm not sure I've ever met a panelist who referred to his intervention as a routine before, so that's a difficult gig to follow. In contrast to the previous chairman, Randall, I'm known colloquially as Peter the Tweeter. And so I want to start with my tweet name right there, and feel free to tweet at me while we're talking or afterwards. I want to compliment Ann, you and your team, for this fantastic conference. Such great ideas brought up, and you've already heard a global perspective emerging. The question I want to ask is whether there are innovations that are occurring in the developing world, in low and middle income, that would actually be of use to Canada, maybe imported into Canada and then re-exported somewhere else as commercial activity. And that's really the focus of this talk. Okay. Can someone just, thank you. So what's an example of one of those things? This is the poster child that most people talk about. This is the Vscan portable ultrasound developed by GE. It was developed in a research facility in India. It costs about $5,000. Of course, larger, more complicated ultrasounds are much more expensive, but this one is very cool. You know, when I was a medical student in the 80s, working with this stethoscope, trying to hear heart sounds, I don't know how many of you have had that challenge. I would have loved to have just taken a little ultrasound probe and been able to look at someone's heart. So this is really a very interesting, disruptive innovation that you see Jeff Immelt there, who actually is the person who wrote one of the original articles on reverse innovation in the Harvard Business Review, sporting. So this is the sort of thing that's typically talked about when we talk about reverse innovation, and it's pretty cool. But what I want to focus on maybe a little bit more is a type of reverse innovation that's very much on the topic of value in healthcare. I think there was reference in that panel before to an article on value, which I take it is the Michael Porter article in the New England Journal on value in healthcare. And of course, value is health outcomes over the costs of delivering health services. That Vscan, it's not that cheap. But it does provide good value because it can lead to a set of health outcomes that are new by bringing ultrasound into the hands of a clinician. What I really want to focus on in this talk, and I'll do that a little bit later on, is a type of innovation, a type of reverse innovation that you might think about as affordable innovation or frugal innovation. Sometimes it comes from the south, from the developing world, so it's called south to north innovation. It's often disruptive, so it's related to this Clayton Christensen idea of disruptive innovation. It can be catalytic, but the key components are that the quality is equivalent or better, but the costs are radically lower. As I mentioned, the ideas can come from anywhere, and the innovation is not equal to science and technology, gadget, gizmo. Can be an innovation in a business process, can be a social innovation, or some combination thereof. But I want to just rest here for a moment, because if you think about it, and you think about the history of innovation in the health sciences, most innovations are a little bit better than the pre-existing technology, but they cost an awful lot more. That is 90% of innovation. Some people have called that sustaining innovation, maybe 100%. And it's actually not that easy to think of examples in our own innovation systems that are primarily on the affordability side. One example that's actually a lot better and a lot more affordable is low molecular weight heparin. I remember as a medical student treating people come into the emergency room with a swollen leg. You'd worry that they had deep venous thrombophlebitis. Of course, the risk of that is pulmonary embolism. You have to anticoagulate them. In the early 80s, those people stayed in a hospital for 10 days, 14 days, getting intravenous heparin. Today, you're assessed in the emergency room, you're given low molecular weight heparin, and away you go. And In other anticoagulation situations like atrial fibrillation, we've now even moved on to oral heparin. So there's an example of an innovation that's much better, especially for patients, and quite a bit cheaper because you're saving 10 days of a hospital stay. But those are really the exceptions rather than the rule. Think about cancer drugs. I mean, normally what you've got there is a drug that is better than the pre-existing drug. Maybe it expands average lifespan by 4 weeks, 8 weeks, 12 weeks. But it often costs a lot more than the pre-existing set of drugs. So that type of innovation is really the most common. And I want to focus on the exception to the rule, which is the idea of reverse innovation. And affordable innovation. So in addition to that example I gave you, essentially from a multinational, GE, here are some homegrown examples of affordable innovation. And a lot of these are in India, actually, which Melinda Gates in a TED Talk referred to as a hotbed of innovation. A lot of them are in India where the price points have to be lower. You've got large populations. You want to provide health care. This is the example of the Aravind Eye Hospital, and it's kind of one of the Indian poster children for this field. So this is essentially does lots and lots of cataract surgery. Also does some other types of operations and eye operations. And on the right side of this slide, what you can see is they do almost as many cataracts or eye surgeries as a whole as the whole UK National Health Service. So over there on the left hand, the immediate graph right beside the picture, green is the UK Health Service, orange is Aravind. So you can see their volumes are very, very high, almost as big as the UK. The next graph over is their costs. They have a fraction of the cost, the total cost. Some estimates are 5% of the total cost. So high volume, very, very low cost. So you're thinking, oh my God, Indian healthcare, nobody would want to import that in the UK, the quality must suck. Well, the graph at the bottom actually has some quality indices. And if anything, they happens to show a number of adverse events like capsule rupture and vitreous loss and so on. If anything, the Aravind outcomes are better. Their adverse events are lower. So this is a high-volume play which has radically reduced costs with equivalent or better quality. Great example of affordable innovation. Imagine introducing something like that to Ontario or to Saskatchewan or to one of our provinces. So how do they do it? Well, I met a guy who was the chief innovation officer of Aravind once, and I said, how do you do it? And he gave me a very interesting answer. He said it was the values of Dr. V, the founder. So he ascribed it actually to the cultural values of the founder, which I thought was a very interesting place to ascribe it. I thought he would talk about the service delivery model, and you can see a picture of that here, where essentially they achieve savings by shifting any task to the lowest cost provider who can do it. So patients are lined up, and an eye surgeon will go from doing a cataract here, it's done, someone else will finish up. Patients prepped over here, goes to the next one, back and forth, very high volumes, and that's their service delivery model. They also have cost innovation on commodities. So they, for example, have developed intraocular lenses in their own laboratory that are much cheaper than the intraocular lenses that you would otherwise buy. But it's a combination of these factors, which is how they do it. But imagine that. Almost as many cataract surgeries as in the UK, which means probably more cataract surgeries than in a province in Canada. 5% of the costs, equivalent or better quality. Could you bring a system like that into Canada? There's some very substantial barriers, actually, to that sort of innovation, including vested interests. And we can talk about that. But imagine if you could. Imagine what that would do to our health spending. Here's another example, very much along the same lines. The Narayana Cardiac Hospital. This is a picture of Devi Shetty, who's been called the Henry Ford of heart surgery, the king of hearts. So he brought an innovative service delivery model on cardiac surgery into India, and some similarities to the Aravind model. And as you can see, his average costs for bypass surgery are $2,000 compared to an average of $6,000 in India, and I don't know, $20,000 or something or more in Canada, and certainly much more in the United States. So radically lower costs, good quality, high volumes. These are some of the service delivery examples coming out of India. Now, another example, going back to multinationals, is this EKG machine from GE, portable EKG machine, low cost, $1,000 compared to $7,000 EKG machines in North America. So far I've talked about sources of innovation that come from multinationals and that come from actually domestic small and medium enterprises, and I've used two examples in India. And I'm really trying to exemplify innovations that are maybe not better in quality. Maybe they're not better. That's what we normally think about as innovation, but they're radically lower in cost. So you're innovating on cost, you're innovating on affordability. And why would that be important? Well, this is not a shocking or surprising slide to anybody. This slide is just the growing costs of healthcare. This is the per capita version of that. This is the Canadian version of that. And when you ask yourself why healthcare costs are increasing, it's not only population growth. It obviously has to do with technology as a major contributor to healthcare cost inflation. And so the normal type of inflation can actually drive costs up, the normal type of innovation. But what we're talking about here is turning the idea of innovation on its head and having a type of innovation that can actually drive costs down. And costs, and especially value, is actually probably one of the primary challenges that any established healthcare system faces, part of the broader challenge of entitlements in advanced societies that are causing huge amounts of economic difficulty as growth lags. You're stuck with entitlements, and you get into the sort of problems that the United States, the UK, and many, many advanced economies are getting into because of the difficulties of entitlement spending, a large part of which is often health care. So I want to just shift for a moment now and talk about a third source of these sort of innovations. And that's an organization that I'm very privileged to be associated with as the CEO. It's called Grand Challenges Canada. And we're about bold ideas, big impact, and a better world. Our chairman is Joseph Rotman, who's a noted philanthropist and entrepreneur. We're only 2 years old. You see the finance minister, Flaherty, there. Minister Flaherty launching us about 2.5 years ago. We're focused on global health. We're funded by the Government of Canada. We fund innovators in low and middle income countries and Canada. We encourage integrated innovation, which I'll talk about in a moment, not only science and technology, but also social and business innovation. We're very interested in impact at scale and sustainability and focused on results, primarily saving and improving lives. And what we noticed, and I want to use some examples of projects that we funded, is that when innovators in low and middle income countries and also in Canada are innovating for the conditions in low and middle income countries, including price points, you end up with some really interesting innovations that are applicable not only to low and middle income countries, but also to Canada and other advanced economies, if only we could get over the barriers of bringing them home. And those barriers are high, and I hope we can talk about them a little bit in the discussion period. This slide just talks a little bit about our concept of integrated innovation. We're interested in technological, social, and business innovation, and in particular, we're interested in integrating them because we think that's what's needed for sustainability and scale. So to take a concrete example, one of the projects we funded was a flocculant swab which had been developed for bronchoscopy but was being applied by actually a Hamilton-based innovator in a hospital in Eastern Africa, related to, in Botswana actually, and it was to collect a stool specimen in kids with diarrhea. You know, there's about 1 million deaths a year from diarrhea. It's a big cause of death under the age of 5, but stool is not an easy thing to collect. And so those are very poorly characterized illnesses, and the treatment is empiric, it's not customized, etc. So he took this bronchoscopy swab, he was using it to collect a stool specimen for diarrhea. That has a science and technology element because it was a particular flocculent swab, not the normal thingamajig swab. It has a business element. The intellectual property is owned by a company called Copan in Italy, and one needs to address that in distribution channels. And it has a social/consumer element because how acceptable is it to parents to essentially do a swab of an infant's rectum to collect a diarrhea specimen? So there's an example where you need to think about all those things up front if you want sustainability and scale. So about half of our business is the STARS program, which is about $100,000 proof of concept grants a year, innovator defined. Your idea, if you're an innovator from low and middle income country or from Canada, you apply to our STARS program. We fund lots of $100,000 grants, and we will, like a venture capitalists, fund some of those with smart money partners to take them to scale. I'm going to come to some really good examples from the STARS program shortly, but you might have seen some of these last week because we announced a round, and it was up on CNN International, it was in the Washington Post, it was in the Toronto Star, on CBC Radio. So you might have heard of some of these last week, but I'll give you some examples that I think are particularly relevant to reverse innovation. That's about half our business. The other half of our business is on 3 defined challenges. Top left is saving lives at birth, because most of the 300,000 women who sadly die every year around pregnancy and childbirth die within 72 hours of birth, and 1.6 million children of the 6.9 million who die under the age of 5 die within 72 hours of birth. So with partners, Gates Foundation, USAID, Government of Norway, and UK Aid, we have a program called Saving Lives at Birth that stimulated 39 innovations for that particular challenge. In the middle, we have another defined challenge on saving brains, which is on child cognitive development. It's not enough to save the life of a child. You also have to worry about what that life will be like and helping children reach their full potential. There's a couple of 100 million children around the world who never reach their full potential because their brains are knocked off by the time they're 1 or 2 years of age from malnutrition, from lack of stimulation from their parents, from infection, from prematurity. So this is tackling that challenge. And that's a picture of kangaroo mother care in the middle there, which has been shown not only to improve child survival, but early indications in a project that we're supporting is that it can also improve cognition and child development from that early stimulation of children. And then the third challenge we focus on is global mental health, maybe the most neglected of neglected diseases. 15% of the global burden of disease. The total amount of innovation funding in global mental health, we just did a back-of-the-envelope calculation, is probably less than $100 million. Compare that to TB, malaria, etc., and we've invested so far $30 million of that $100 million on innovation in service delivery and global mental health. And the picture is of a friendship bench in Zimbabwe with a lay health worker essentially counseling what looks like a woman with probably maternal depression, which is the most common mental health challenge. And a lot of these innovations are service delivery innovations because the problem here is there are 250 times as many psychiatrists per capita in Canada, say, compared to Ethiopia. And so you really have a skilled health worker type challenge. So that's a little bit about Grand Challenges Canada by way of background. But what I want to do now is just pick up on 4 examples of projects we funded, the problems they address, because it represents a very interesting set of examples and stream, I think, for this topic of affordable innovation or reverse innovation. So the first challenge I want to talk about is the challenge of tuberculosis. So the incidence of tuberculosis per 100,000 people in Canada is 4.7 per 100,000 overall. In low-income countries, 264 per 100,000 overall. So that's what you would expect, right? Tuberculosis is relatively low in Canada as a whole, relatively high in low and middle income countries. But look at the figure for the northern province of Nunavut in 2010. It's 305 per 100,000 people. So actually, the incidence of tuberculosis in Nunavut, according to these numbers, is higher than the incidence of tuberculosis in sub-Saharan Africa. So we do have a problem with tuberculosis in some parts of the country. Now, the weak link in the chain in tuberculosis is diagnosis, and actually reaching into remote communities and diagnosing tuberculosis. And so a couple of the technologies we funded, in this case they are technologies, are aimed at tuberculosis. On the left, you see Karim Karim from the University of Waterloo. He's developed a new pixel technology, which he's put into a digital X-ray. It's radically cheaper than existing digital X-ray devices. We funded him to test it for chest X-rays for tuberculosis in India. But you could imagine its reverse applicability once he proves the concept in that particular context. On the right is Ranjan Nanda, who's a researcher at ICGEB, a research institute in Delhi. And Ranjan noticed that the fingerprint, the breath of patients with tuberculosis is different than patients without tuberculosis because of certain volatile organic compounds in the breath. So it's almost like fingerprinting the breath of a tuberculosis patient, or think about it as a tuberculosis breathalyzer. So he's developing that for the diagnosis of tuberculosis in remote Indian villages. Remember, diagnosis is the weak part of the chain. But imagine the applicability of that in remote settings, northern settings, against tuberculosis in Canada. So there's one example, tuberculosis, potential for reverse innovation. I'm not arguing that these things are all cascading immediately into Nunavut or into Canada. They obviously still have proof of concept work to do in the developing world. What I'm really trying to do is to show you the potential and to show you the dream. And it is incredible. And this Ranjan Nanda one, by the way, we co-funded with the Gates Foundation. Let's look at a second problem, limb loss and congenital limb deficiency. So there are 32 million amputees worldwide. 24 million of them in the developing world do not have access to proper prostheses. This is one of the problems that we don't think about so much, but it's a very, very serious issue in disability and in quality of life. In the developing world, an important cause of this is landmine survivors and having lots of trouble with access of prosthetic knee joints and prosthetic legs. Of course, in richer countries, it really is a problem closely linked to social determinants of health, often having to do with obesity, diabetes, and it is associated with education, income, labor, employment, lack of insurance, and ethnicity in terms of people with diabetes, etc., who actually come to the point of amputation. In Grand Challenges, we funded this guy, Jan Andrusek, who is developing the LC knee. So what he did is he figured out a different type of polymer that would make the knee joint work better and differently, and it's much cheaper. So he developed this knee that he's showing you on the right-hand side of the slide. And the key thing about his knee is it costs about $50 compared to $2,000 to $3,000 for normal knee prostheses. So we are funding him to evaluate that knee, prosthetic knee for landmine survivors in the developing world. But at the end of the day, he's going to have a $50 knee. And he'll know the operating characteristics of that knee. It'll be stripped down. It won't be as fancy as the $2,000 knees. But think about the applicability of that for knee prostheses in Canada and in other countries. And that's going to become only a greater problem in the future. This slide deals with a fourth challenge, the challenge of diabetes, as diabetes increases in Canada and in the developing world in the future. And this slide shows diabetes projections for 2030. And you see a couple of things. One is that in the U.S. and Canada, there's obviously going to be more diabetes as there's more obesity, and more diabetes will equal more more amputations, more vascular disease. But look at the changes in the developing world. First, look at some of the large emerging economies. Look at India. 79.4 million people with diabetes projected for 2030, 164% increase. Look at Southeast Asia, almost 60 million people. These are huge numbers of people with diabetes. So again, diabetes, which you think about as a rich world problem, is migrating all around the world. Look at Sub-Saharan Africa, 18 million people with diabetes by 2030, 162% increase. So again, an example of a problem that we share. This is a researcher from Western University that we funded to develop. This is almost like a lens implant. So it's like you use for seeing better, but it measures the blood sugar on a continuous basis. And so it's a risky technology, may or may not work out. Risky in terms of can it get to proof of concept, may or may not work out. But an example of a technology that's being developed, in her case, I think for China, that has wide applicability also back in Canada. Actually, this is the fourth example I want to give. This is Jeremiah. Jeremiah lost his wife in childbirth just a week or two before this picture was taken. I already told you the shocking statistics of maternal deaths around the world. Most of those deaths are preventable. So these are pictures of maternal mortality. There's obviously some regions that are higher than others. And one of the key features of, one of the key causes of maternal mortality, or one of the top 3 or 4, is preeclampsia, high blood pressure in pregnancy that's not detected. We funded some researchers at UBC in Vancouver to develop this very interesting technology called Peers on the Move. So this is a smartphone-based application that measures blood oxygen using a probe attached to a smartphone and different type of software. We funded them actually for 2 reasons. One was a project measuring the oxygen level of pregnant women, because that plus some other characteristics can be used to predict preeclampsia. That's the Peers on the Move thing. But think about the applicability to, but we also funded them for an application on childhood pneumonia. Because very little measurement of oxygenation, which is obviously a predictor of the death of children. Again, more than 1 million children die from pneumonia under the age of 5. So very significant problem, interesting technology. And then to extend that, think about all the operating rooms in Africa. Here it's totally routine that you'll have oximetry on a patient undergoing surgery. In African operating rooms, I think about 60% of patients undergoing surgery actually have oximetry. And that's a big safety issue, obviously. So you need a low-cost device. That's what these folks are developing. So it's not the $800 or $1,000 regular oximeter. It's not the $300 oximeter that's low cost, recommended by WHO. It's much cheaper because it's essentially a thing you plug into your cell phone with some software. Obviously, very applicable in the developing world, but think of the potential both for remote communities in Canada. Think about remote and Aboriginal communities and issues of maternal care there. And think about the affordability issues, actually, of oximetry in the field and the potential for reverse importation of that technology. So let me just do a quick summary. We'll have a little discussion, and then I want to move on to a special treat after that. Most of the innovations that we've talked about, most innovations that we think about, if you think back over the history of the last 20 or 30 years of innovation, are things that are a teensy little bit better and a heck of a lot more expensive. And that pattern of innovation is one important factor, obviously not the only factor, that drives escalating health costs in rich countries. Except the only problem is that rich countries are getting poorer because of those escalating health costs and other types of entitlement programs. So something needs to be done to control the inflationary rise, And one thing that can be done is to think about a different type of innovation, not focusing on the extra 4 weeks of life from the latest multi-million-dollar tumor-shrinking cancer drug, but focusing on innovating on radical affordability, where the thing you end up with, which, by the way, could be a technology, could be a service delivery model, could be a different type of business model, some combination of the three, the thing you end up with may not be any better than what you've got now, but it'll be a heck of a lot less expensive. And that type of innovation is really, really worth stimulating. When you ask yourself, in other words, you have much greater value because you're working on the denominator. If you ask yourself, where do those innovations come from? Many of them come from multinationals, and I gave you the example of the Vscan and the EKG machine from GE. Many of them, interestingly, come from small and medium enterprises in India, and there's a conference next week on affordable innovation in India. And what I'm proposing is that some of them can actually come from the pipeline of innovations that we think about as funding global health or global development generally. And that's why I use the example of Grand Challenges Canada and the example of the low-cost prosthetic leg, the handheld oximeter that's on the slide, and so on. Now, where are we at with this? Can I give you a single example of something that has been effectively reverse innovated and taken out costs in a rich world health system? I can't. What I showed you was modeling. If the Aravind model was imported into the United Kingdom, you'd have equivalent quality and take out 95% of the costs. Well, just think for a moment about all the barriers to importing a service delivery model like Aravind into the United Kingdom. Think about the regulatory barriers. Think about the cultural barriers and the branding issues. Think probably most significantly about the entrenched interests that exist in the system, the economic interests of providers that exist in the system. And I'm sure there are many, many other barriers. There are all sorts of barriers to doing this. But paying attention to the potential of this and actually demonstrating one or two of them could be revolutionary for our health system, because good ideas come from everywhere. Talent, if there's one thing I've had the privilege to learn in Grand Challenges Canada, it is that talent is global. Ideas, even very poor countries are very rich in ideas. What's missing is the opportunity to match to that talent and those ideas to move them to where they need to be. And that's actually, that gap is fundamentally what we're trying to do in Grand Challenges Canada. Imagine taking the investment that Canada or other countries are doing in development, in global health, in innovation, that we're doing anyway for the purpose of improved health outcomes, saving and improving lives in the developing world, and building on that investment to actually deal with our own main problem, our own health system, and the cost escalation therein. That would be a fantastic virtuous cycle. And my friend and colleague Will Falk will tell you that the next step, by the way, is to take something that's been proof of concept in the developing world, re-import it into Canada with some clear regulatory system and passes muster in Canada, and then export it to the United States where the regulatory barriers are even higher. But we're not even yet at step 1 to step 2, let alone step 2 to step 3. So it does fit with the topic of the earlier panel as well. Imagine a world like that. Imagine a world like that. That's the world that we want people to focus on, and that's where I'm trying to lead you with these examples. Not only the poster child of the Vscan and the poster child of Aravind, but what I've introduced in this talk that I think you won't see in other discussions of reverse innovation is this pipeline creation that development agencies essentially, or development funders, are doing that can then be used for or built upon for an even further purpose. That's also good, by the way, for development, because creates another market opportunity for these innovators, and will pull things even more significantly in situations of market failure in the developing countries themselves. So I'm going to just pause here for discussion. I'm not quite done because we have something else to do that's very exciting, but I'm just going to pause here. I'm going to thank you. I'm going to remind you of my Twitter name so we can all tweet at each other after this. And I want to thank Caitlin McMaster, who's at the back of the room, who did a lot of the research and helped pull together this, this presentation. So thank you very much to Caitlin and to all of you. Here's the background of what we've done in this book that you can get on Amazon. That's my free commercial. I'm going to pause here. Hope we can have a little bit of discussion. And then don't go, because about 10 minutes after, we'll just have maybe 10 minutes back and forth, and then we've got something very, very exciting that Anne and I and others would like to share with you. So thank you, and let's just have a real brainstorm about this, because this isn't the answer. This is only a glimpse of the dream, and we need your help in figure out how to actually move from where we are to where we need to be on this topic, because the barriers are significant, but the opportunity is also great. So thank you, and I look forward to your questions. Fire away. Please.
Hi, sorry, I couldn't resist because of the mention of the UK associated with some of the work that Arvind was doing as well. It's quite interesting because the biggest challenge always is the introduction of a system within a system and the management and the managing of the vested interest within the system. And I think there is a way to overcome this, and it is around having a really quite clear idea as to how you're going to overcome them and actually getting assistance in the overcoming of them. So a business plan must not necessarily be purely economic, because this is disruptive, yes, but its disruption is its greatest difficulty. It is so disruptive, it can't be used. So finding ways around the system is what this is about, and I think this is where perhaps the centre can assist, because there are solutions, but people don't address them.
Yeah, I think that's a very thoughtful comment. So I had a conversation once with a leader who had been the CEO of a very large health system in the western United States, very focused on quality. She'd also been a key leader in a global health foundation. And we were tackling just this very question. And her considered view is you could never take one of these technologies, stick it into an existing health institution, and expect it to do well. Essentially, what you needed to create was a health organization, and even more so, maybe a health financing model associated with that organization that could compete in the market with a bundle of these interventions. So imagine a health plan or a health clinic associated with a health plan where your premiums were much lower, your range of services was there, your quality was just as good, and that was your value proposition. But her point was you could never take the Aravind model and stick it into a hospital down here on University Avenue, because the folks who were associated with that hospital would kill it, because it's not in their interest for it to survive. You have to create its own organizational structure, which I think is why it was interesting, now albeit for different reasons, that the answer of the Chief Innovation Officer of Aravind to how did you do it, what's the secret sauce, was the values of the founder, flowing from organizational values. He didn't go to their service delivery model. He didn't go to their technological innovation. He went to their core organizational values and purpose. And I think an extrapolation of that is exactly what you said. You have to pay attention to the barriers. I think it is a great focus for the center, and it's very funny you mentioned that. We'll come to that in a second. And also the idea of how you do this in an institutional context where it won't necessarily be welcomed, notwithstanding the incredible public purpose that could be achieved. So thank you. Any other questions or comments, please?
Thank you, Dr. Peter. My name is Dr. Dipankar. I come from India, so I'm really pleased that you're talking about India a lot. And incidentally, I'm an MBA student at Schulich now, being a physician also. I've worked not for Dr. Devi Shetty and Nahindalai, but I've worked with them. Probably, I'm just giving my inputs and my idea of looking at it. I think the intent is, of course, there. The intent, of course, is noble. But at the same time, when you look at India and the way he works, is that the kind of volumes that Nahida generates. Like you have one surgeon operating only on tetralogy of Fallot, and he'll only do that surgery, and he'll not do anything else. To be able to import that structure and that frame to maybe Canada or maybe the UK, do we have that kind of volume? So probably it's not really, and I think that's what you hinted at, it's not really the volume or the exact model that you want to import, but maybe the intent coupled with how to get around the system. That's what you spoke about. One thing which is striking out and what I came to know of once I came here is that, as you said again, so much is being spent on healthcare here that probably it'll take the steam out of the boat, and you also get poor sometime. So probably the way of looking at it and way to innovate is spend less and think about how to get more efficient results out of spending less. So I'd like to know from you whether you think the intent plus the model which is suitable for the country plus the belief that you should get more out of less, all these three combined can only give you a result and not really any one in isolation. Thank you.
Yeah, I think you're pointing the idea that it's a messy area. The complexity you described is important. I think the mix will be different on different innovations. But let me just make a couple of points. One is this issue of volume. So let's say you don't have the volumes in an Ontario, in a Canadian province that you can get in Aravind. And let's say you're 10 times less efficient than Aravind, and you're dealing with labor costs, etc. And let's say that instead of saving 95% of the costs of cataract surgery, you fail 10 times and you get 5%, you multiply it tenfold, you get 50% of the costs, and you're only saving 50% of the costs. I think that would be an acceptable deal, and it goes back to the perfect shouldn't be the enemy of the good comment that came out from the last panel, and just do it. I also want to reframe a little bit the intent. So there's no question that Dr. V's intent and the intent of Aravind was a noble intent to provide vision care to the poor in India. No question about that. And in fact, that's why that organization is successful. That doesn't have to be the intent of the reverse innovation play. The intent of the reverse innovation play, you could frame it as a noble intent, namely the idea that we're helping Canada deal with this terrible social problem of escalating health costs. But why not also frame it as the intent of making money? There are huge margins here that could be achieved if this innovation can be successfully pulled. So this should be of just as much interest to a finance minister of a province as it should to the venture capitalists of the province. So I want to just come on to this intent question, because I think we need to be reflective about what our intents really are, and they can be profit maximization. If you get a situation that's profitable for the investor, that is good for this escalating cost curve, provides good care to patients, it's just win-win-win. So I just wanted to land on a couple of parts of your wonderful question to flesh out a couple of the ideas. And maybe let me just add one more. We're blessed in Canada with very strong diasporic populations. And one of our largest diasporic populations is people of Indian origin. I think about 1.2 million, 1.3 million Canadians, you probably know the number better, are originally of Indian origin. Those people can serve, Canadians of Indian origin can actually serve as a type of cultural bridge for plays like this. And so there may actually be a very interesting comparative advantage that Canada has relative to other developed countries in terms of reverse innovation if you link that idea with diasporic innovators as well. So thank you very much for your comment and question. Just wanted to flesh out a couple of aspects of it. We'll take one more comment/question, and then we got a really wonderful surprise for you.
So
you're
going
to love this.
Yeah. I'm Patty Mead. I'm a recovering former deputy minister who now does research. But I also spent a lot of time in the north, and I think it's more a comment and a challenge that Canada also has areas where it's not even about reverse innovation. We don't have the tools and technology, and yet we have incredible innovation happening north of 60, small pockets of providers who are using technology and using lay professionals and all kinds of things that we're now looking at other countries for. What they lack is capacity to actually even write them up or to spread. But I would, I guess my comment and my challenge is that while your organization is also looking at large countries and developing countries around reverse innovation and how it fits in urban Canada, there are lots of lessons learned and perhaps a better laboratory north of 60 or in other rural, remote parts of Canada. Thank you.
Yeah, Patty, I just want to actually underscore the value of what you're saying. You know, global health used to be thought about as people over there. And Anne mentioned I had the privilege of chairing the first major assessment on Canada's strategic role in global health. And we outlined a number of scenarios and strategies for global health in the country. But the only truly original contribution of that report was to say that our concept of global health in Canada should also include Aboriginal and Northern health, and in particular health research. And so I just really want to underscore what you are saying. Now, that's easy to say, difficult to do, but let me give you an example of one tiny place where it's been put into reality. In this Grand Challenges business, you know, it started with the Gates Grand Challenges, $500 million, mostly infectious disease, mostly technology, starting in 2003. Then my colleague Abdullah Dar defined the Grand Challenges in Global Non-Communicable Diseases. A group of research organizations from 7 countries formed around that, called the Global Alliance for Chronic Disease. They launched their first request for proposals on hypertension implementation research. And hypertension kills more people from stroke that's preventable. It's just an incredible waste of human brains. Because totally preventable hypertension, and hence the focus on implementation research. But to your point, Patty, what I found really exciting about that was one of the first requests for proposals that I saw that specifically emphasized drawing innovation from developing countries, from Aboriginal communities, cross-learning, sharing lessons. So I think, you know, talent and ideas are everywhere. The opportunities to exploit and develop them and actually take them to a point where they help your own community and other communities is what is lacking. And so I think that we ought to be very open as to the source of innovation and support the best ideas wherever they come from. In terms of lots of parts of Canada, you can get pretty good support for your good ideas. Not all parts of Canada, as you pointed out, in terms of Aboriginal communities. In terms of developing countries, a lot harder. That happens to be a mandate of our organization, Grand Challenges Canada, but that doesn't mean that I can't or shouldn't be able to completely support the point you made, because it fits into the general principle of the gap between ideas and opportunities. So with that, I'd like to thank you, and have we ever got a special thing for you, because this is not really only about ideas. This is about now a call to action. So if you were going to do a call to action on the topic of reverse innovation, who would you focus it on? Well, obviously, you would focus it on students and young people, because what we've got is a set of incredible barriers, which we've only just started to talk about, between us and this opportunity that I've tried to define in this talk. So what we're pre-announcing today is a very exciting challenge called Color Outside the Lines, Reverse Innovation. And this is has a number of partners. This will be an open call for Canadians to become active participants in shaping the future of our health system, and particularly capitalizing on the opportunity and challenge of reverse innovation. The purpose will be to leverage the power of crowdsourcing to generate reverse innovations that will drive change for Canada's health system. The challenge will focus on finding innovations that are being successfully applied in the developing world, emerging markets, and I think we should take under consideration the point, Patty, you just made about Northern and Aboriginal communities that offer potential innovations for our own system that improve the value of care, which could mean doing things better, but it could also mean doing things just as well, but much more affordably. The challenge will invite student innovators to submit their innovation project ideas, ultimately with the goal to develop and test the innovation in Canada. And it will go beyond just the project idea to the business model, to identifying the barriers to reverse innovation, a point that's really come out very clearly in our discussion here, and ways to surmount those barriers. The first place prize will be one $50,000 award, and second and third place prizes will receive $25,000. The specifics of this grant application, which is why I referred to it as a pre-announcement, will be open on January 15th, 2013. The partners in this challenge include the ones you see on the slide: Medtronic, TELUS Health, and Roche, along with the Sandra Rotman Center and the Ivy International Center for Health Innovation. I think this can be a real game changer. We're going to need your help to spread the news about this to your students, to spread the idea of the challenge to other countries. And I know we are extremely thrilled, and to be a part of this. And again, I really want to compliment you and your team for coming up with this, for assembling the partners around this. So this is going to be our call to action, to actually move the ball down the field of the ideas that we've been talking about. And I'd now like to invite these partners to share a few words, beginning with Neil Fraser, who's the president at Medtronic Canada. Neil, and thank you all very much for your attention.